Hi, everybody. This is a presentation on pharyngitis, a common condition that you will be seeing in your practice, especially this time of year as it's cold and flu season. Pharyngitis is a sore throat. It can be viral or bacterial, and complications of group A beta strep pharyngitis include acute glomerulonephritis and acute rheumatic fever. However, that's more common in the younger population, although we'll touch briefly on it today. Tonsillitis we're going to also talk about, and we're also going to include mononucleosis. Pharyngitis accounts for about 11 million visits annually. It has a viral etiology in greater than 50% of patients. It's important to keep in mind. Most people that have pharyngitis will typically think or be convinced that they have strep throat. If it's bacterial, the most common agent is the group A beta hemolytic streptococcus. 1 in 4 children test positive. It's not necessarily something you're going to see a lot of in the adult population, but you do see a fair share. 43% of families with an index case have a secondary, and it happens in the later winter, early spring, and are mostly the peak seasons. It's transmitted via respiratory secretions, and the incubation period is 24 to 72 hours. So typically within 1 to 3 days, you'll see patients saying they're complaining of sore throat, especially if they've been exposed in the dates prior. So what is it? Is it group A strep or is it viral etiology? More of the common characteristics in group A strep is a sudden onset with a fever of greater than 100.4 Fahrenheit, with myalgias, a headache, and a certain possible known exposure. Typically, patients have cervical node lymphadenopathy and pharyngeal or tonsillar inflammation or exudate. It can be accompanied with nausea and vomiting. And a lot of times you'll see this palatial petechiae and this scarlatina-form rash, which is highly specific, but not always happening. The rash is almost like a sandpaper-like rash, and again, that's more common in children, but you can see it in the adult population. The palatal petechiae is also another finding, and that's basically more in the upper palate. The rash or the redness is not necessarily diffuse, it's more scattered. If somebody is of a viral nature, they have a more insidious onset of a sore throat after a constellation of symptoms. They have a cough, they've got a runny nose, they might have conjunctivitis, they could have diarrhea. Their viral symptoms are just that. They are happening with viral colds. They have a sore throat, but they have a cough. They have a sore throat, but they've also got other symptoms. So that would not necessarily direct you to being suspicious that somebody had strep throat. However, with that said, if somebody has a cough and has swollen glands and has a runny nose, but you look at their tonsils and you see that their tonsils are enlarged, that they've got exudate, it would certainly warrant making sure that you ruled out for group A strep. This is a picture. It's not a very good picture, but this is a good picture. So what I was talking about is palatal petechiae. There's just some red, diffuse, little scattered bumps in the back of the throat. Strep throat. This is a classic case of strep throat where there's exudate on the tonsils. Sometimes the tonsils don't have any exudate, but they certainly are enlarged and red. The scarlatina rash, like I was talking about, is fine sandpaper rash. It's not really red, and it's typically on the upper chest. As far as lab testing goes, we don't necessarily do a lot of lab tests to find out if somebody has strep. We typically do a throat culture. The rapid antigen detectant testing is very sensitive. It's very specific. It allows for earlier treatment, symptom involvement, and reduced spread. But false negatives can be certainly a problem. So throat cultures are usually the way to go. They've got great specificity, great sensitivity. They're not the most comfortable thing to have done. If any of you have had a throat culture in the past, you know what that feels like. But certainly if you get a good swab, you can certainly get a good diagnosis right off the rip. As far as antibiotic selection goes, You can go to a number of different resources. You can hit Hippocrates, you can hit the current book, you can hit up to date, you can look at the Sanford Guide for Antimicrobials, and you'll always see that the first line of treatment still is penicillin. We know that there's a lot of penicillin resistance out there, but penicillin is still recommended by the American Academy of Family Practice and the American Academy of Physicians. A single IM dose of penicillin is thought to be the best, but people don't usually like to get that because it can be a little uncomfortable. So amoxicillin by mouth is really the way to go. It tastes better. It's available as a chewable for people who can't swallow pills. And typically, strep throat needs to be treated for 10 days. Treat the throat culture results positive for non-group also. So if somebody has a positive test, or you're not really sure, but you're thinking that somebody has a group A, but they test negative, but it still looks like it could be a strep throat, I would still go ahead and treat. The current U.S. guidelines recommend erythromycin for patients with penicillin allergy. However, the side effects are a lot of abdominal pain and diarrhea. The erythromycin, this extended release erythromycin, tends to have quite a big side effect profile. So we usually go with the azithromycin or the clarithromycin, which is the Zithromax and Biaxin, because they have less of a side effect issue. I will say, though, that azithromycin is growing in its resistance in the community, so we're not seeing as good of a turnaround or good of a reduction in symptoms on this medication. Cefadroxil or cephalexin, which is Keflix, are both generation cephalosporins. They're great drugs, but they have a 10 to 30% cross-reactivity to people who've got penicillin allergies. So please make sure that when you're prescribing it, if they have an allergy to penicillin, you're really not going to want to put them on cephalosporins unless they've had cephalosporins in the past. It says in this slide that children may return to school 24 hours post-treatment. That goes the same for adults. They usually need to be on the antibiotics before they're not considered to be contagious. People who have recurrent group A pharyngitis tend to be needed to be treated with different antibiotics. Typically, IM penicillin G is recommended if they were previously prescribed an oral because it's thought to be have a better coverage and a better outcome. People who are chronic strep carriers are those people that test positive for group A without active infection for 1 year despite treatment. They are not at risk to develop a post-strep complication like a glomerulonephritis. Their risk of transmitting group A strep is low, and you only should treat these people under the circumstances that they have recurrent groups. They have a lot of group A strep within the family that they live in. Their personal history of close contact with acute rheumatic fever or acute post-strep glomerulonephritis. But if they test positive for strep, but they don't tend to have symptoms and nobody else around them is sick, there's not a real reason for you to be constantly treating them. This should really resolve itself within the year. Complications of group A strep include glomerulonephritis, rheumatic fever, peritonsillar abscess, and retropharyngeal abscesses. Glomerulonephritis occurs 1 to 3 weeks following a strep throat, whether the throat was treated with antibiotics or not. The primary symptom is hematuria. So it's very important in your assessment to find out, in your history taking rather, if you have somebody with blood in their urine, if they've been sick in the past few weeks. It can lead to hypertension and edema and impaired renal function. Typically, this happens in the younger age group, but if you're in an adult practice and you're treating people of college age, this is something to also look out for. Rheumatic fever, again, happens typically in the younger ages. It is a sequelae to a strep infection. Typically, the signs begin 2 to 3 weeks after infection. Again, the peak onset of age is 5 to 15. And rheumatic carditis and valvulitis may be self-limited, or they can also lead to problems in the valves themselves. The two most common valves are the mitral and the aortic. A peritonsillar abscess is the most common deep infection in the neck in young adults. It's despite the widespread use of antibiotics for treating pharyngitis. The incidence happens in the 20 to 40-year-old age range. I've seen a lot of peritonsillar abscesses lately. It happens most commonly in November to December and April to May, which coincides with the onset of pharyngitis, when we see pharyngitis the most. This is a picture of the anatomy where you see the tongue and the uvula and the tonsils, and what happens is there is inflammation in the peritonsillar region. This is a picture of a peritonsillar abscess. So the uvula is lying back here, and then the peritonsillar abscess is all this inflammation that's in front of the tonsil. People that have peritonsillar abscess usually appear sick. They don't feel good. They've had a fever, body aches. They definitely complain of a sore throat, but they have very much a hot potato voice. They have a lot of throat pain. They usually say it's on one side. They have tender cervical lymphadenitis. They might have trismus, which is an inability to open their mouth. And if they don't go treated, or rather if they go untreated, they tend to have airway obstructions, hemorrhages, and they can also develop a septic necrosis to that tonsil. CAT scans and MRIs don't necessarily need to be done, although it is suggested. This is something that needs to be treated immediately. So if you can't get them in with an ear, nose, and throat person, if you're in primary care, they need to go right to the hospital, because sometimes they need to be treated with a more aggressive IV antibiotic and then get an ENT consult. One more thing that I wanted to say about just about peritonsillar abscesses is that a lot of times the biggest clue is that they have what's called this hot potato voice, or this phonation. And typically they have a really hard time swallowing their saliva. And we've learned about that a lot in the children, in the pediatric population, but you really should make sure that these patients have patent airways and that you document that they are able to swallow, their breathing is patent, etc. Infectious mononucleosis is usually presented with a fever, malaise, headache, arthralgias, fevers. They have sore throat and swollen glands. They have a lot of post-cervical adenopathy. They might complain of some nausea, vomiting, or abdominal discomfort. Peak age is 15 to 19 years old, but again, we've seen this in the 20-year-old age group. The usual cause of this is the Epstein-Barr virus, and it's transmitted via saliva, which is why they used to call it the kissing disease. Incubation period is usually 4 to 7 weeks, and in about 60% of patients with infectious mononucleosis, they have an enlarged spleen. So if you are suspecting that somebody does have mono, or might have mono and has a sore throat and fever and all that stuff, you need to make sure that you palpate and make sure that they don't have any splenomegaly. The lab test for mono is there's a couple different tests depending on where they are in their diseases. The white blood cell count in a CBC usually is significantly high, and it has 50% lymphs. The heterophil antibodies in the monospot with a monospot blood test is usually positive, but they have to be 1 to 3 weeks after the infection is known. And it's 100% sensitive between 4 to 6 weeks, and it stays positive for months to years later. So if you check for mono in somebody a year after they've already had it, it might be positive, and you won't know that they have actual current disease. The other thing that happens is that the patients can have what's called a viral hepatitis, so their liver function tests will be elevated. So you can do a complete metabolic panel as well as a CBC to look for elevated liver function tests in this patient population. And then an Epstein-Barr virus titer can actually tell you whether the patient is sick with current disease or if it's convalescent or not. Typically, management for mono is supportive. No antibiotics are needed. They need to eat. They need to be drinking a lot of fluid, and they need to get in a lot of rests. They have no contact sports for 3 to 4 weeks, especially when they have splenomegalia. And if you are on the fence as to whether they can go back or whether there's an issue, you can always send them for an ultrasound of the spleen and have the spleen measured to make sure that it is not enlarged. The one thing too about these patients is that sometimes they'll complain of a sore throat and they might have a concomitant strep infection. And if they do have a strep infection, you need to treat them with an antibiotic. But in patients who have mononucleosis with a strep infection, if they get a penicillin, they may develop a rash. So we usually tell people, or we usually don't prescribe amoxicillin and penicillins for patients with strep throat if they have mono. If they develop a rash, we don't know whether it's a rash from the strep throat, or I'm sorry, from the penicillin, or if it's a rash, actually from the strep throat itself. And this is the references that we have. The American Academy of Family Practice has some great references online. And then use the current book because that's always more up to date. Please let me know if you have any questions. And we'll move on to the next presentation.